out. Right. Very good. Right. Shall we make a... Very good. Okay. So first of all, as per usual, shall we go through things from a little bit of revision from what we did from the last session? Hope you guys have done your homework. So this is what we were focusing on last time. We were looking at ST segment elevation and depression in the context of acute myocardial infarction. So if we're going to look at how we're going to assess our ST segments, we're going to draw a line down here through our isoelectric line, joining our PR interval to our TP interval. And normally our ST segment is flat. It's along that line. If your ST segment elevation marked in this red line, you can see that there's a difference between the horizontal line here, drawn between here, and our isoelectric line. And similarly, ST depression, we're going below the line. When we look at a myocardial infarction with a full thickness myocardial infarction, where you've got a complete coronary occlusion, we get a characteristic pattern of changes. We start out with a normal looking QRS complex. After about an hour or so, we get ST segment elevation. At the 4 to 12 hour point, we start developing a large pathological Q wave. So unlike these little things, which are tiny and insignificant, pathological Q waves are more than 25% the height of the subsequent R wave. From then on, we get progressive evolution of the T waves. So we get T wave inversion, which eventually, weeks to months later, normalizes, leaving a Q wave behind. So that's the sort of pattern that we get with an ST elevation MI. And we can make a pretty good guess at which part of the heart is affected and which coronary artery is causing it by looking at the region of the ECG that's affected. So we have our inferior leads, which are pointing downwards. That's leads 2, 3, and AVF. And they're normally the right coronary artery or potentially the circumflex. We have anterior, which is leads V1 to V4, which is generally supplied by the left anterior descending coronary artery. And we have our lateral leads, which is V5, V6, lead 1, and AVL. And they're more likely to be supplied by a branch of the circumflex. So those are the rough coronary territory. Those are a rough landmark of the regions of the ECG and the areas of the heart that it reflects. So let's see what the questions were. So for ECG, we're going to look at whether there are any signs of current or previous ischemia or infarction, and if so, what? Which region of the heart is most likely to be affected? And are there any other abnormalities, rhythm or intervals? Okay, so the homework's getting trickier each week, isn't it? Okay, so as per usual, everyone's going to get a go at this. There's no use running away, Anne. You're going to get called at some point. So who wants to go first?
I can go first.
Excellent.
So yes, there was signs of ischemia or infarction. There was T-wave inversions that we could see, or that I saw. And I saw those in leads 1, AVL, in leads 2 as well, and then V2, 3, 4, 5, and 6. So it was an anterior lateral infarct, I believe.
Very good. And when do you think this is likely to have occurred? Is this likely to have occurred in the last hour, or is this something that's happened a little while ago?
This is likely to have occurred 48 to 72 hours ago.
Excellent. And what makes you say that?
Because the timing for a T-wave inversion is 48 to 72 hours. If it was just 1 hour ago, then you would more likely see an ST segment elevation. Very
good. So we've got these deep Q waves, and we've got this progressive T-wave inversion. Absolutely spot on. This is an anterolateral ST elevation MI, probably from a good 2 to 3 days ago. Very good. Next.
I can go.
Excellent.
Detected ST elevation in lead 2, 3, maybe V4, 5, and 6.
Excellent.
Perhaps this is located more in the inferior part of the heart.
Very good, very good. So inferior, 2, 3, and AVF, and lateral, yep, and V4 to V6. Excellent. Infralateral. Very good. And do you think, and how old do you think this is? Is this a new infarct, or is this something that's been going on for a while?
I guess it's. I'm not so sure about this, but perhaps it's been going on for a while.
Wow,
It's
okay.
I guess the third phase.
Okay, well, that's
I'm not so sure about that though.
It's been going on for a while, but if we remember our sequence, the first thing that happens is you get ST elevation. Then after that, we're starting to get development of Q waves, and there are no pathological Q waves in any of these leads, are there? There's this tiny little thing here, but it's less than 25% the height of the subsequent R wave. So it's not really a significant Q wave here. So this is probably quite early on in the process. Very good. Okay.
Oh, okay.
Was there anything else that you noticed about this ECG? Any other abnormalities in this ECG, apart from the stuff you correctly identified about this being an infralateral MI? Anything about the rhythm? Does it look like a normal rhythm?
I'm looking. Well, it seems regular.
Are you sure it's regular? Let's have a look at this rhythm strip.
Well, yeah, well, there is, yes, a gap. It seems as though it's starting the second.
Yeah.
After the second QRS.
2 beats gap, 3 beats gap, 3 beats gap.
Oh,
3
yes.
So it's not regular, is it? So anyone else? Does anyone want to help Claude out? Anyone else got any thoughts about what might be going on here?
Is it ventricular trigeminy?
No. Good guess. I mean, trigeminy is a good idea because it's got 3 things together. Can you see any P waves?
There's 1 P wave for every 3 complexes.
Excellent, Lauren. Very good. So what does that mean then?
I'm not too sure.
Okay, but very good. Well done. Well spotted. So we've got P wave, QRS, P wave, QRS, P wave, which is hard to see, QRS, P wave, no QRS. And then it starts again. P, 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 P is missed. So, and every time the PR interval gets longer before this one drops, and then it gets short again. So you get progressive lengthening of the PR interval until one drops, and then it starts again. So can you remember back to the rhythm lecture what that meant?
Is that second degree AV block?
It is. Excellent. Second degree AV block. And can you remember what sort of second degree it was? Remember the Justin Timberlake takeoff?
Wanky back.
Diagnosis wanky back. There we go. Excellent. Fine. So this is wanky back. So the reason that we've got this. So we've got we're having an infralateral ST elevation MI with wanky back because the same coronary artery that supplies this region often supplies the atrioventricular node as well. So the AV node is getting damaged by this myocardial infarction. It's struggling. So electricity is still getting through. The AV node struggling, and it's starting to block. Okay. So very good, guys. Tricky one, that one. Next.
I'm sorry, Charlie, just to interrupt quickly.
Yeah. Oh, I think you're frozen. Oh, are you back again?
We typically interpret do we still consider that as an elevation? Like I still got inferior lateral. I just wasn't sure how to categorize leads V1 and V2.
Okay, so leads V1 and V2, we've got ST segment depression going here, and it's quite and as we talked about before, if you're having an ST elevation MI, in the leads which are opposite in the heart, ones that have got the ST elevation, then you'll often get ST depression. Okay. That's what we've got going on here. They're called reciprocal changes. All right, next one.
I'll do the next one, Charlie.
Great.
So the rate is about 45 to 60.
Mm-hmm.
It's irregularly irregular.
Yeah.
Um, I had down that it's the beginning of an MI because lead 1, AVL, V4, 5, and 6 have inverted T waves.
They do. That's right. Very good.
V1, V2, V3 have Q waves.
Do they have Q?
No, they don't, because it's the opposite, right? Okay, wait.
Wow. Because remember a Q wave is if the first deflection is negative. So if you can see here, the first deflection here is positive. So that's going to be an R wave. The second deflection is negative. So that's going to be an S wave. So there aren't Q waves in these leads. This is an R and then an S wave.
Okay.
Okay.
And then I had that it's inferolateral region.
Okay, excellent. Okay, well, these are good thoughts. So it's certainly involved. So I'd certainly agree with lateral. So it's certainly involving V5, V6, AVL, and lead 1. Yep, I'd certainly agree with that. I'm not sure about the inferior part of it because the inferior leads are leads 2 and 3 and AVF. So this in the right sort of context. This is reflective of ischemia because we've certainly got T wave inversion here. We may have some subtle changes in the ST segment here. It's possible. But they're pretty subtle anteriorly, and so this could be some ST elevation here, or this could represent a non-ST elevation MI. But you're certainly right that in leads V1 to V6, 1 and AVL, we certainly have marked T wave inversion. I think I'd probably call it anterolateral rather than infrolateral, but I think otherwise you've got it absolutely right. You're absolutely right. The heart rate's pretty slow. And what do you think the rhythm is?
Irregularly irregular.
Okay. And why do you think it's irregularly irregular? Yep, I'd agree that there is one early beat here. I completely agree.
There's also hyperacute T waves in lead 3.
Okay, yeah, they're quite pointy in lead 3. Yep, you're absolutely right. Yep, very good. So this is a sinus bradycardia. We've got one early beat. So this is a premature atrial activation, or premature atrial complex. So it's a PAC, early P wave here, but otherwise it's a sinus bradycardia. And you're absolutely right. This is there's anterolateral T wave inversion, and I would agree that these T waves are pretty pointy in lead 3 as well. Very good. Next.
I can take this one.
Yeah.
So I thought there was ST elevation in the precordial leads in V1 through V4.
Mm-hmm.
And then ST depression in lead 2, 3, and AVF.
Very good.
And then T wave inversion in, I guess, AVR and V1, I think.
Okay.
And then I don't think there were any Q waves. And the part affected would probably be anterior.
Okay. So you don't think there are Q waves? So do we think the first deflection here is positive or negative in V1?
Oh, that would be a Q wave.
Yeah, I think that's a Q wave. What about here?
That would also be a Q wave.
I think that's a Q wave too. You could, and there may be a slight hint of an R wave there, but yeah, it certainly doesn't look normal in V3 either. So if we've got, so in these anterior leads, V1, V2, if we've got deep Q waves, we don't have any T wave inversion. What does that suggest about this this pattern here? What does it suggest about what's going on? Does it suggest this is old or new?
Old then?
Yeah, really old. So this might have been something that might have happened years ago. Okay, this is so if you've got Q waves, but the T waves have renormalized, that suggests that this is probably going to be pretty old. So sometimes you can get this pattern where you get some persistent ST elevation, particularly if you remember, if we talked about it being concave like this, sometimes that's just a reflection of an old myocardial infarction where it always stays like this. This brings home the fact that when we're interpreting ECGs, you also need to have a chat with people as well to work out what's going on. And if someone says, yeah, I had a heart attack 5 years ago, but I'm feeling fine now, then it probably, then that's not necessarily something acute. I do agree that the things look rather different in the inferior leads here. So I think you picked up all the abnormalities there. Well done, very good. Fine, last one. Who's going to go for this one?
I can do this one.
Excellent.
I thought there was ST elevation in grade 3.
Very good. Yep, I quite agree.
So that would be inferior.
Hmm.
And
So I
then
agree with that. So what's going on in the second half of the trace?
it's a ventricular tachycardia.
Yeah. So it could be it looks like a polymorphic ventricular tachycardia, doesn't it? Yeah. So I agree. So this is one of the reasons why myocardial infarctions kill people, because they get dangerous ventricular arrhythmias. This is someone who I agree has got inferior ST elevation. Then halfway through the ECG, while the ECG is being recorded, they then go into this rhythm that looks like polymorphic VT to begin with. Maybe it turns into something more. Maybe it turns into something more regular at the end of it. But it's very fast. Looks very nasty. This is the sort of thing where if you don't do something about it quickly, then there's not going to be a good outcome. So very good. Excellent. So we've got ST interpretation and rhythm interpretation all in one go. We're starting to build these things up. Excellent. Good work, guys. So
I have a question.
yeah, Claude, go for it.
It seems as though when I was doing this, well, I could find a bit of everything in different leads. It seems as though some leads are saying some things and some leads are saying other things, and this might not be the same thing. Is there a priority in leads that we say, oh, we should look at this lead, this is more important? Or
No. But if you remember, we've got our coronary territories here.
yes,
So,
yes.
So if you've got something that's related to a myocardial infarction, it may affect the whole heart, but it's probably not going to. It's pretty bad news if it affects the whole heart in one go, because you'd have to be multiple coronary arteries all at the same time, which is unlikely. But if it does happen, it tends to be pretty lethal. So it tends to be a region of the heart that is affected. And therefore, if it's a region of the heart that's affected, then then you're going to pick up some of these ECG changes in some parts of the ECG, not others. So you can do it as you talk about it as a descriptive thing. So you say there might be some ST elevation or some Q waves or some T wave inversion in these leads, and then that is consistent with the idea that this could be a myocardial affecting the lateral region. So it's not that there's a priority of things. When you're interpreting an ECG, as we're going on through the weeks, we're building things up from the most simple to the more complex. But you end up with a description that's not necessarily going to be a 3-word description. It might be a 5-line description to say, this is a sinus bradycardia. In these leads, I can see this. In these leads, I can see this. Overall, this is consistent with a. So it's not that some leads have more priority than others. You've got to look at the whole lot and take it all into context.
Well, it's more of an art than a science, isn't it?
Absolutely, it's a bit of both, and a lot of it is pattern recognition.
Mm-hmm.
You're absolutely right. There's science and art to it. There we go.
Hey,
anyway,
Charlie, quick question. Sorry. Is there certain leads that you're always going to find that the T wave is inverted, or is that just because V1 to V3 is what I'm kind of seeing that is normally the T wave is going to be inverted in those leads, and is that how we should be? Is that what's the normal for that, or?
So T wave inversion in lead V1 and V2. T wave in V1 is inversion in V1 is normal. T wave inversion in V2 is also pretty common. If you're getting T wave inversion beyond that point, it's generally abnormal. So from V3 and beyond is more likely to be abnormal. In lead AVR, you can often get T wave inversion as well.
Okay.
Those can be normal findings.
Thank you.
No worries. Right, let's go on to the next bit. So what we're going to be talking about here is bundle branch blocks. Now, this is relevant for this is going to be relevant for you guys in when you get to interpret some ECGs, because it's these are really pretty relevant to inherited conditions and influence your interpretation of what's going on. So, what is a bundle branch block? What are we talking about here? So, if this is normal, if this is our wiring diagram for the heart, so just like we saw in the first lecture, our waves of electricity are starting out in the sinus node, traveling throughout the atria, going through the atrioventricular node, down through the bundle of His, and then they separate out. So separating out into bundle branches. We've got one bundle branch going to the left ventricle, the left bundle branch. This splits in two, so you've got one. So you've got an anterior and a posterior fascicle. So anterior at the front, posterior at the back. So, but we've got a left bundle branch here. Then we've got a right bundle branch that goes out towards the right ventricle. For the purposes today, we're just going to concentrate on the fact that in general we've got a left and a right. Okay, so what happens if we get some kind of disease process that's affecting one of these bundle branches? We know what happens if we've got disease affecting all the way up here at the AV node or the proximal bundle of His, because we've looked at atrioventricular block, first degree, second degree, third degree. What happens if we've got disease that's selectively affecting one of these bundle branches? How's that going to influence the ECG, and is it important? Well, it is important, and this is what it's all about. So, as you'll remember, our heart's composed of lots of myocytes, and these myocytes, they're all electrically connected, and the electricity will flow slowly from myocyte to myocyte. However, if you've got specialized conducting cells running through the middle of it, like a bundle branch, the electricity moves really quickly. So, in short, if you've got an intact bundle branch, you get rapid conduction. If your bundle branch gets disrupted, then the electricity can still get through, but it gets through much more slowly. So if we've got intact conduction all the way through, from our sinus node through our AV node, bundle of His, bundle branches, Purkinje fibers, we're getting rapid conduction all the way from top to bottom. Because of that, it only takes a very short amount of time from the start of ventricular depolarization to the end of ventricular depolarization. So that's marked as narrow QRS complexes. Narrow complexes on a surface ECG represent rapid conduction, which represents the electricity traveling through the normal specialized conducting tissues of the heart. Okay. If you haven't got narrow complexes, it suggests that there's something that the electricity is traveling through something other than just the normal conducting system, and at least for a part of it is traveling myocyte to myocyte, just through the muscle tissue rather than the conducting tissue. So, what about a left bundle branch block? What happens if we can conduct normally down the right bundle, but our left bundle is blocked? We get a broad QRS. Our QRS complex lasts for more than 120 milliseconds. This can be if the left bundle has become damaged for some reason. Now, it may be that the left bundle isn't conducting at all. It may be that the left bundle is conducting, but it's just conducting very slowly. It may be that the left bundle just takes longer to recover than it normally does. And so at slow heart rates, it may conduct normally, but at rapid heart rates, it may fail to conduct. So there are several reasons why you can get this functional block of the left bundle, but either way, it leads to a similar sort of ECG pattern. And we're going to start out by looking at V1. Lead V1 is the lead that we're going to look to when we've got broad QRSs to try and tell us what's going on. You've got to remember V1. You're going to have a QRS that's more than 120 milliseconds. 120 milliseconds is our cutoff to say what's normal and what's not. And in V1, you're going to get a negative QRS complex. Okay. In the lateral leads, which is 1 AVL and V5 to V6, you're going to get positive QRS complexes. And just as a result of the fact that the left bundle is not working properly, you can get some ST elevation occurring here as well. Regardless of whether there's any active ischemia going on, a left bundle branch block by itself can cause some ST elevation. So that's what it looks like in V1 with our broad QRS, potentially with some ST elevation. what does it look like on a 12-lead ECG? Oh, sorry. First of all, I ought to mention the relevance to inherited arrhythmia syndromes. So various cardiomyopathies, such as dilated cardiomyopathies or hypertrophic cardiomyopathies, can give you a left bundle branch block pattern, because these can the scarring that occurs with these disease states can influence the conducting system of the heart. But also, crucially, we're very interested in things like long Q in measurement of the QT interval. The QT interval is from the start of the Q wave to the end of the T wave. If you've got a broad QRS complex caused by a left bundle branch block, this is going to prolong your QT interval, but merely by prolonging depolarization rather than affecting repolarization. So it's important to recognize a bundle branch block and mention that when you're interpreting QT intervals. So this is what it looks like on a 12-lead ECG. Here we've got sinus rhythm. You can see P waves, QRS, T waves. You can see that in lead V1, which is the one that we're going to particularly focus on, our broad QRS complexes are negative. They have a small, in this case, we've got a small initial upstroke, but then it's predominantly negative. In the lateral leads, lead 1, AVL, V5 to V6, we've got predominantly positive QRS complexes. You can see that the ST segment isn't completely flat. The ST segment is very slightly up in these in leads V1 and V2, and that's a normal feature of a left bundle branch block. And in the leads in which the QRS complexes are positive, the ST segment appears to be slightly depressed. Okay. In this case, we can also look at the axis. You can see that we're positive in 1 and we're negative in AVF. You can remember from our lecture on axis that if we're positive in 1 and negative in AVF, that's a left axis deviation. And you can often get a left axis deviation with a left bundle branch block pattern as well, although it's not entirely essential. Okay, so these are the sorts of features that we get with a left bundle branch block. But the key thing is, these are the features that go along with it. But if you're going to remember one thing, or two things really, you've got broad QRS complexes that are negative in V1. Okay. That's what a left bundle looks like. Now, the left bundle branch block can be seen regardless of what's going on in the atria. So in this case, we've got a left bundle branch block. We've got broad QRS complexes, greater than 120 milliseconds, negative in V1. Okay, but here, where we've got atrial fibrillation going on at the same time. Okay. Right bundle branch block. On the other hand, so if the left bundle is intact, but the right bundle isn't conducting properly, in this case, we get a different sort of ECG pattern. Once again, for a complete right bundle branch block, our QRS complex is going to be more than 120 milliseconds. But this time in lead V1 or V2, we're going to get positive QRS complexes, which have this funny notch pattern. You get an R wave, then an S wave, and then you get a second R wave. We call that an R prime pattern. You get an RS R prime pattern. And R prime, you mark it out with a little apostrophe like this. So you get this RS R prime pattern, which looks a bit like bunny ears, which that's my little rabbit. So V1 or V2, broad QRS complexes, RS R prime, bunny ears. This time in the lateral leads, you're going to have a negative QRS complex. You're going to have an S wave, negative QRS complexes in the lateral leads. The S wave occurring at the end of the QRS complex. So it may start out with an R wave, but it's going to end up negative in an S wave. So once again, this is what it looks like on a 12-lead ECG. We've got sinus rhythm here. We have an RS R prime pattern with a broad QRS complex. In the lateral leads, we have a terminal S wave. So we've got a positive initial component, but we've got a negative component that's broad at the end of the QRS complexes in lead V5, V6, lead 1, and AVL. Okay. Now, this is what it looks like in a complete right bundle branch block pattern. You can also get an incomplete right bundle pattern, which is a similar sort of thing. You get this RSR prime pattern in V1. You get an S wave laterally, but the QRS complex is less than 120 milliseconds. So that suggests that rather than it being a complete blockage within the with a complete absence to conduct within the right bundle, it suggests that it's slow conduction instead. That would give you an incomplete right bundle branch pattern. Okay, but apart from that, the QRS morphology looks pretty similar. You can also get right bundle branch block with different things going on at the same time. So in this case, we've got right bundle branch block, broad QRS complexes, RSR prime pattern, S waves in the lateral leads. But in addition, what do you think is going on with the axis here? So the axis here, we're positive in lead 1, we're negative in lead AVF, positive in 1, negative in AVF. That suggests our axis is going up in a northeasterly direction. So we've got left axis deviation. If we've got a right bundle branch block and a left axis deviation, that suggests that the conduction disease is a bit more widespread. We've got a technical term for that. We call that a bifascicular block. The disease is even more widespread. Here we've got a right bundle branch block, RSR prime pattern, QRS more than 120, S waves in the lateral leads. We have a left axis deviation, positive in 1, negative in AVF, but also we've got a really prolonged PR interval here, haven't we? This suggests that the conduction disease is even more widespread. We're affecting the right bundle, left axis deviation, and first degree AV block, so a PR of more than 200 milliseconds. We're going to call that a trifascicular block. Okay, so it's a progressive. These patterns are progressively showing more and more disease of the conducting system. That's going to, if this carries on, if it gets any worse than this, it's going to progress to complete AV block. So that's what those are the sorts of patterns that we get with if we've got damage to the conducting system affecting the right or the left bundle branches. The next thing that is going to be important for you guys to know about is what we do when we've got damage to these conducting systems and what it looks like when we're doing something about it, when we're looking at pacemakers. So pacemakers are a little box that often sits under the left shoulder with a wire, 1, 2, or 3 wires that lead through the veins down to the heart. This is what it looks like on a chest X-ray. Box by the shoulder, wires coming down to the heart. Okay, and the function of a pacemaker is to detect if the heart is going too slowly, and if it is going too slowly, speed it up. And it can speed it up by sending little electrical pulses through these leads to automatically stimulate the heart. This is something that will be used in some of our inherited cardiac conditions patients, and it'll certainly be seen in some patients in the HERO registry on their ECGs. And it's important to recognize because it influences how we're going to report these ECGs and how we interpret them. So what does it look like? If we've got a wire that's plugging into the heart, in general, not universally, but in general, this wire is going to be plugged directly into the muscle tissue. It's quite difficult to plug it directly into the conducting tissue. It's possible, but in general, that's not what's done. And so most of the time, this is plugging directly into the muscle. This means that the electricity that flows out from this wire when the heart starts contracting isn't going to use the normal conducting system. It's going to be traveling myocyte to myocyte. So the ECG pattern that we're going to get is going to be similar to a bundle branch block. The way that you can tell that there's pacing going on is because when you get that when you get that pulse of electricity traveling down through the wire, you're going to see it as a little spike. The spike is very, very narrow. It may be big, it may be small. It depends on how the device is programmed. We don't need to go into the technical details of it, but sometimes they can be really obvious and sometimes they can be really little. But if you look closely, you will see them. Here, we've got a pacemaker that's plugged into the atrium. And here, the ECG pattern that we're going to get is a little pacing spike directly before the chamber of interest. So in this case, the atria. So we get a pacing spike, then we get our P wave. We're then going to go through the normal conducting system. And so in this case, if the conducting system is intact, we're going to get a narrow QRS complex followed by a normal T wave. So the way that you can tell that this is atrial pacing going on is purely by the little spike that's occurring before the P wave. Now, if there was already disease in the conducting system, if the patient had a baseline right bundle or left bundle branch block or something like that, you'd see that pattern as well. But for a lot of patients who just need pacing in the atrium, you'll get a narrow QRS complex. On the other hand, if you've got a pacemaker that's plugged into the right ventricle, which is the conventional spot for it, this time you're going to get a pacing spike followed by a broad QRS complex with a left bundle branch block pattern. So we're not going to be conducting through the His-Purkinje system in the left ventricle. We're just going to be conducting myocyte to myocyte. It's going to be conducting slowly. And so we get a left bundle branch block pattern when we're pacing from the right ventricle. So pacing spike, left bundle pattern. If we've got leads in two chambers here we're pacing the right atrium. We've got a pacing spike before the P wave here. We've then got another pacing spike before the QRS complex. And again, the QRS complex is broad in a left bundle morphology. This is both atrial and ventricular pacing. And this is the sort of pattern that you're going to get on the ECG for that. Okay. There are other more complicated forms of pacing, if we get a third lead in, if we go for biventricular pacing. But in general, whichever form of pacing you're using, if the pacemaker is actually if the pacemaker is actually firing, if it is needed at that time, and if it's working, you're going to see a pacing spike followed by immediately preceding the electrical signal from the chamber that you're interested in. If it's not working, you might get a pacing spike without anything after that, but that's a whole different story. So let's have a look at some 12-lead ECGs. So here we can see we've got when you first look at it, the whole thing looks a little bit confusing because you've got a load of extra lines here. But what we've got, if we look closely, is we've got a P wave, a QRS complex, and a T wave. P, QRS, T. But before every P wave, we've got a very large, very thin spike. This very large, very thin spike doesn't represent doesn't represent anything in the heart itself. This isn't any muscle contracting. This very thin spike is a pacing spike. It's a very big pacing spike in this case, because of the way that the device has been configured. It's something called unipolar pacing. You don't need to particularly know about that, but sometimes this is why you can get very big pacing spikes. The PR interval is long here. So the AV node itself isn't very happy, but things are getting through. So we've got atrial pacing here. Pacing spike, P wave, long PR interval, QRS complex, T wave. And here, the QRS complexes are narrow because we're using the His-Purkinje system. This ECG has got pacing spikes, QRS complexes, and T waves. Here we've got a roughly left bundle branch block pattern. I say roughly because we're broad and we're deep in lead V1. It's a roughly left bundle pattern, but not quite, because in lead V5 and V6 we don't have those positive leads. We're negative all the way down, but it's still a roughly left bundle pattern caused by our right ventricular pacing. If you look really carefully, and some of these are a bit difficult to see, you can see P waves that are in there. P buried in this ST segment, P at the end of the T wave, P in the ST segment, P here. If you map them out, P that's right on the end of the T wave, which is why this one looks particularly pointy, P in the middle of the QRS, P here. So we have got P waves that are going on here. We have got paced QRS complexes going on here, but they're going at completely different rates. So this is someone who's got a temporary pacemaker in, but the only lead that's in place is in the right ventricle. There's nothing that's going on in the atria, and the reason the temporary pacemaker in is because this patient has underlying complete heart block. None of the electricity from the P waves can get through the AV node, and the very simple sort of pacemaker that's in at this time doesn't recognize that there are P waves in place, and therefore it's putting the QRS complexes in at times that are completely dissociated from the P waves. Okay. Here, we've got atrial pacing. We've got pacing spike, P wave, relatively normal PR interval, and QRS complexes. Again, we've got what looks like a left bundle type pattern, but this time there aren't any pacing spikes before the QRS complexes. These ones are the pacing spikes here are relatively small. In some leads, you can barely see them at all, but they are there. Those pacing spikes are there before every P wave. But there's no pacing spike before the QRS complex. So here we've got atrial pacing with an underlying left bundle branch block. Here we've got dual chamber pacing. We're pacing both the atria and the ventricles. We've got pacing spikes that are very small that you can see just before the P waves. You've got a pacing spike before every QRS complex. But here the QRS complexes don't have that broad left bundle branch block pattern because it's a special sort of pacemaker called a biventricular pacemaker that leads to much narrower QRS complexes. Okay, but either way, we've got pacing spikes before the P waves and before the QRS complexes. Okay, so if we're putting all these things through together, we can have we've talked about bundle branch blocks, and we've talked about pacemakers and the things that the sorts of patterns that we get with that. And we've got a few more examples of ECGs showing these things. So here we've got sinus rhythm with a right bundle branch block pattern, broad QRS, RSR prime pattern. Here we've got a different sort of abnormal atrial rhythm with a left bundle branch block pattern. So we've got a tachycardia going on here, and our P waves looking pretty abnormal. This is an atrial tachycardia with a left bundle branch block pattern. Here we've got another example of pacing. We've got dual chamber pacing, pacing the P waves and the QRS complexes, with so pacing spike before each P wave, pacing spike before each QRS complex. Another example of dual chamber pacing. Here we've got an example of atrial pacing with a right bundle branch block, seeing how we were mixing these up. Atrial pacing, tiny little pacing spikes here before each P wave, followed by QRS complexes with a right bundle morphology. And that's it. Any questions about pacemakers or bundle branch blocks?
Charlie, could you repeat what your how to distinguish and kind of what bifascicular and trifascicular blocks are again?
Yeah, absolutely. So if you're looking at our right bundle branch block with our positive RSR prime pattern in our in lead V1 or lead V2, it should be more than 120 milliseconds for a complete bundle branch block. If it's just a right bundle pattern, then that's all you're going to see. You've got a right bundle pattern, but our PR interval is normal, and our axis is normal here as well. So positive in 1, flat in AVF, pretty much isoelectric in AVF, normal axis. That's what a normal right bundle branch block looks like. If you've got additional features, then it suggests that other things are affected as well. So Right bundle branch block by itself, normal axis, normal PR interval. Right bundle branch block, normal PR interval, but left axis deviation, so positive in one, negative in AVF, suggests that you've also got some involvement of one of the fascicles of the left bundle, and that's what we call bifascicular block. So right bundle branch block with left axis deviation. If you've got, but still with bifascicular block, you've still got a normal PR interval. Suggests that the conducting system's a bit more diseased. The conducting system's getting even more diseased if we've got right bundle branch block and left axis deviation, and now we've got a prolonged PR interval. That suggests that the conducting system's hanging on by a thread, and if it gets any worse, you're going to start getting high-grade AV block. Does that make sense?
Yeah.
Okay. So the sorts of inherited conditions that might lead to this sort of pattern that we're interested in would be sodium channelopathies. So the sorts of things that the sorts of genetic conditions that cause conditions like Brugada syndrome can also give damage to the conduction system like this. So you can get bundle branch blocks, bundle, right bundle, bifascicular, trifascicular, high-grade AV block. The sodium channelopathies are one of the big things that are going to lead to this sort of pattern. So if you're doing any studies that are involving things about Brugada, then being able to recognize these sorts of ECG patterns is important. Anyone else got any questions? Okay, good stuff. Fine. So next week, I think we've covered most of the background stuff that we need to be able to start putting some of our inherited stuff into context. So I think next week we're going to try and look at some of the inherited conditions themselves in a little bit more detail, and so we can use some of the information that we've already got. I'll send you through some homework slides again to go through the stuff that we've learned today, and I'll see you guys